terms of people getting, what we say about evidence-based treatment, 90% of persons with substance use don't get medical attention. Many times it's not real evidence-based treatment. Can you comment on that? Because if as people are struggling in and out of this, they go into the right place, they're getting the right help. Can you comment on this?
I'm Neil Capreto. I'm the medical director with the Gateway Rehabilitation Center. I've been here 25 years. I started at St. Francis over 30 years ago, and I'm an addiction psychiatrist. Addiction is a chronic disease. Unfortunately, our healthcare system treats it like it's the flu. You just get this short-term dose of treatment. The National Institute of Drug Abuse, NIDA, recommends for all addictions, even low-level ones, that people should get a minimum of 90 days of continuous treatment. It doesn't necessarily have to be inpatient, a combination of inpatient and outpatient, and people do better when they get more. I've worked with the Pennsylvania State Physicians Health Program. It's a program that monitors doctors who have alcohol and drug problems in the state for over 25 years. This disease does not discriminate. Every state has them. It's a very intensive 5-year monitoring program. And you know what the success rates at the end of 5 years are? 85 to 90%. Okay? Now people say, well, they're doctors, they're different, they have a lot to lose. Well, yes, they do have a lot to lose, but do they have more to lose than a mother losing their child or people losing their families? What is really different is they are treated, they get an intensive 90 days to 6 months up front, then they're monitored with urine drug testing. I mean, we wouldn't try to treat diabetics without monitoring blood glucose, yet we treat people with addiction and don't check their urines. They're good like 3 times a week the first year, 2 times a week for the next 5 years with all kind of monitoring. If we offered that type of treatment to everybody, we'd get better results. Now, critics will say, well, that's too expensive, but I beg to differ. It's more expensive not to do it. For every dollar you put into drug and alcohol treatment, society saves back at least maybe $7 to $10 and reduce medical costs, legal costs. So it is a good investment. Even if you don't care about humans, which all of us, I believe, do here, it is a good economic investment. So the important thing with treatment is you're going to go to, licensed credential treatment programs, but the important thing is to stick with it. There is not a magic bullet. I mean, my mentor, Dr. Aidan Torsky at St. Francis years ago taught me addiction is a biopsychosocial spiritual disease. We're not treating computers with viruses. We're treating human beings with mind, bodies, and spirits, and good treatment will address it. Do they have mental health needs that should be addressed? Do they have social needs? Is there a medicine that might help them along and assist them, not alone as a treatment, but as part of a total recovery, and get them involved with ongoing recovery?
Thank you so much, Dr. Clark, in terms of getting people the right treatment, but a concern a lot of people have is the follow-up care. So can you comment on what you do and where do people go for that to make sure they have that kind of intensive treatment?
Absolutely. First, I want to just thank you for all the hard work you've been doing in this area in drug addiction over the last couple of years, because I've been talking to your field director. He's been very helpful, and you've been very committed to this, and thank you for that. Appreciate it. I think, Neil, thank God Neil's here, because he always says it better than me. Thanks, Neil. But I can add that I'm in the trenches treating folks with opiate dependence, opiate use disorder now. I've got your grandmothers, I've got your sons, I've got your mothers and fathers, I've got your doctors, and I've got your pastors. And this disease is not discriminating. It's a chronic disease. We know that people get very good success, and many parents have said this, when we follow them hand to hand over the course of a few years, maybe 5 years. You walk with the patient. In our clinic, we've designed, I've been doing psychiatry 30 years, addiction maybe 8 years now, and the patients will tell you what they need. They want somebody to hold their hand through the recovery process. They want you to give them all the tools that you have that are safe and effective. Evidence-based medicine. They want to know what they are, and they want those options. And they want you to follow them hand to hand over every month. We tend to see them on average once a month, and we bring them in more often when they're struggling or having difficulty. And like Neil said, it's a complete treatment. It's not just a medicine, it's not just counseling, it's evidence-based. And each person, you have to tailor that. I'm here to tell you that it can be done. It's happening now. We have very effective treatments. I have a clinic now of 700 patients, and everybody's doing very, very well. We should go over to South Hills, come on and visit us, okay? You'll see. And the reason we're doing this is because I've got 5 kids, you know? They're grown. Your kids are our kids. Your kids are my kids. If they're sick, I want to get in there and help them out. The problem I'm having, Congressman, is the accessibility. As was mentioned before, doctors are fearful, maybe even not even knowledgeable about it. We have 6 or 7 family practitioners who now are comfortable prescribing and treating addiction because they have an in-house psychiatrist, they have all the support in that area. Dual diagnosis. How many clinics do dual diagnosis? That's very, very important. I'll shut up after this, which is this. My thought is this. We have the willpower, we have the resources, we have the desire to get rid of this problem. We have a lot of great people working in many different areas. We don't have coordination. We don't have coordination. I would suggest, I'll say this to you, you're the one that decides this, something like a task force that can oversee the coordination of all these efforts to get it all done.
There's lots of the comments I want to get to. I'm going to talk about what I'm doing at a federal level. I'm going to go to the state level. I'm going to go to Senator Ward or maybe the county level to hear some of this. We'll get back to some of your comments as well. So I told you earlier that I was tasked to investigate what's happening in our country with the shootings, those tragedies, etc. And what I want to show you is some of a year-long investigation I did with my subcommittee oversight investigation. And what I did was I introduced this bill called the Helping Families in Mental Health Crisis Act. What we found in our investigation is that 1 in 5 Americans have a behavioral or mental health disorder. 20%. At some time during their life, people will have that. From the very mild, transient sadness, acute, mild disorder, to severe and persistent schizophrenia, bipolar disease, and severe depression. 11 million Americans have severe mental illness. 2 million go without treatment. The federal government spends about $125 billion a year annually on the mental illness, and this includes some substance abuse issues too. Much of that is to get people payments for SSI, disability payments, and oftentimes that's it. Here's your disability payment. We'll see you on Medicaid, go get your treatment. But none of those wraparound services. What we also found is there was a real shortage of inpatient treatment beds. In the 1950s, there was 550,000 psychiatric hospital beds in America. Now there's 40,000. Twice the population, 150 million in the 1950s, 317 million now, but a fraction of the beds. Pennsylvania only has 18 beds per 100,000 people. You need about 50 to 100. There are only 7,000 child psychiatrists, and you need about 30,000 for the 15 million kids in need. But I might add to that those who really specialize in severe mental illness, that's severe. This isn't just, I had to practice as a psychologist, and I'll end up getting a lot of, I wrote a book called The Angry Child, and so I will end up getting a lot of those kind of cases that are, but it's different to have a suburban practice versus someone who says, I want to see the most difficult, depressed, heavily addicted, schizophrenic, suicidal, incarcerated people. Those, doctors just don't want to do that. So it's very, very rare, an endangered species. There's also this HIPAA rule. Some of you parents may have found this. So the health, how does that stand for? Insurance, private, portability, HIPAA. And also another rule called FERPA, the Family Educational Rights and Privacy Act. That began, FERPA began as a law because someone had their grades posted on the bulletin board, and other kids saw it, and kids got teased, and their self-esteem got hurt. So someone came up with this law and said, let's make sure that students' grades and things are private. That morphed into, once someone reaches the age of majority, teachers, doctors, and others won't tell the parents what's going on. What's the age of majority in Pennsylvania? 14. It amazes me at age 14 in Pennsylvania, you can't have a checking account, probably can't open a bank account without someone co-signing, you certainly can't get a car loan, drive a car, get a license. You can't do much of anything, but by golly, if you're drug dependent, if you're severe depression, and your mom and dad wants to find out what's going on with you, they're not allowed, they can't find out unless you sign a waiver. It's a serious problem. What's that? Yes, but they can find you. Like when my daughter was at Penn State, I couldn't get her grades, but they found me to give me the bill. So this is a problem, and parent after parent came before a committee with tragic stories and saying, one of them said, I told the doctors in the emergency room, listen, there's another doctor in this hospital, go talk to this is the person in this building who treats my son, you need to find out about this. We're not allowed to take information from this. They really are, but, and the parents would say, I need to give you more information of what's going on. No, we don't want to have this. And the parents said, tell me what's going on, I want to help, I'm part of this kid's life. No, we're not allowed to tell you, it's confidential. Well, there are laws about confidentiality for good reasons, but what we found is they're getting misinterpreted all the time, so introduce the bill to change it. There's also an imminent danger standard. So again, in an emergency room, you can only be able to keep someone if they show up there at an imminent danger to themselves or someone else. And you hear time and time again when you have these tragedies, that someone shows up in an emergency room and they can just say, I'm fine, I'm not going to hurt myself, I'm not going to hurt anybody else, and nobody can do a thing about it in Pennsylvania. It's not an imminent danger. And that is a problem. And if you look at some of these cases, was Adam Lanza in imminent danger? No. Was Aaron Alexis, the Navy Yard shooter, in imminent danger? No. Was Richard Baumhammers in the southwest of Pittsburgh in imminent danger? Well, he signed himself in a couple of times. He was not put in against his will. So this isn't working. The other one, there's no requirement of evidence-based treatments for grants. The Substance Abuse and Mental Health Service Administration, $3.5 billion budget. They don't really require what I would consider scientific standards for these things we found. Then we also found, of course, the mentally ill are no more violent than the rest of the population, but they're 2.5 to 4 times more likely to be the victims of an attack. Children, mentally ill children, 3 times more likely to be sexually or physically abused if they're mentally ill. That's phenomenal. That alone should say this system isn't working and we've got to do something about it. But what happens is if you combine severe mental illness and substance abuse, you increase that risk of violence 4 to 5 times. But if they're in treatment, you can cut that risk 15-fold. But guess what? They can't get the treatment. Not enough providers. We moved a bill to have mental health parity, but that's still not working. I don't know what I did, Brad, fix this. I touched something. It's his computer, I don't know what I did. You got all kinds of, look at your emails all kinds. Okay, so what we do in our bill is we move to empower parents and caregivers to deal with HIP and FERPA laws differently, fix the shortage of inpatient beds, provide alternatives to institutionalization, but there's something else. Someone talked about how things aren't coordinated. We found that the $125 billion is spent in the Department of Health and Human Services, Department of Justice, Department of Education, Department of Defense, Department of Veterans Affairs. What am I missing? We think there's some in the Department of Labor, Department of Transportation, Housing and Urban Development. It's all over the place. Is it coordinated with agencies? No. So one of the aspects of my bill is we want there to be an Assistant Secretary of Mental Health and Substance Abuse, whose job would be to go throughout all these agencies, find the money. If the program works, help states know about it. If it doesn't work, eliminate it. If it has lousy results, change it. If it's duplicative, morph them. We don't need to be spending administrative money in Washington, D.C. We also have a thing there that has to be evidence-based, so we have that Assistant Secretary then in charge of this $500 million in grants that goes out to states and say, states, we're not just sending you the money, you have to show us what you're doing. It's got to be evidence-based. And as the states send it out, there's a different incentive. And one of the things is something called assisted outpatient treatment. Remember I told you it was the imminent danger standard? New York has one where it's different. So if someone has been incarcerated or they have been violent, instead of the situation where someone says, you know, you ought to take your medication, you ought to be in treatment, you know, follow up, and they don't, and they end up in jail, they say instead, what we're going to do is the judge is going to say, you need to be on this medication, you need to be following treatment with your psychiatrist, your physician, your psychologist, your nurse practitioner, whoever it is, your psychologist. And if you're not, then we're going to put you back in the inpatient. New York found they reduced jail time by 70%. They reduced homelessness. What has happened is when we closed all these hospitals, we increased prison populations. So it's a big X. Hospital rates went down, prison population went up, homelessness went up. So we've traded the hospital, we've traded the hospital bed, the jail cell, the flop house mattress, the blanket under a bridge, and a coffin. Last year in this country, 750,000 suicide attempts, 38,000 deaths. Horrible. That does not include ones that may have been intentional drug overdoses or accidental. That's a different category. But so this is what we're looking on a federal level to make some substantial changes. Let me ask what the state's going to do to coordinate this. Can you help us, Mr. Secretary?
We have a lot going on, but one of the points I really wanted to make was about the evidence-based treatment. Confirm what our doctor at Gateway talked about. We have a treatment diversion program for people that are getting locked up for serious offenses. This has been going on for about 10 or 15 years, and a study is about to come out showing the effectiveness, and they use evidence-based treatment. By evidence-based, I mean they get long enough treatment. It's an individualized assessment. It's based on the level of treatment is based on the Pennsylvania client placement criteria. The recidivism rates, and nationally, generally for treatment diversion, you reduce recidivism, that's new crimes, by 2/3. In this study, it shows a recidivism rate reduction, that the recidivism rate is 13.9%. For those of you who've worked in law enforcement, and I spent 26 years working in the district attorney's office in Philadelphia, those are amazing results for people who've gotten drunk driving convictions and they've gone into treatment when it's done with clinical integrity. 2.9% recidivism rate. Amazing, amazing results. So the one point I just wanted to make was treatment really works. And in Pennsylvania, when we have the adequate funding to pay for the treatment with clinical integrity, the results are amazingly effective. Nationally, though, this is the national situation. Nationally, we fund enough treatment. We have enough money to pay to treat one person for every 10 people with a disease. In the state, we do better. It's 1 for 8. Under the Healthy Pennsylvania proposal, that's going to get even better because it's going to expand more resources for treatment. But when you are looking at people that are trying to figure out, like your county drug and alcohol directors, like anybody who's dealing with this issue, and you're trying to figure out, what do? I have this huge number of people, and this 1 out of 4 families, this large number of people suffering from addiction, and I have this small pot of money. And it's hard to know what to do. If you treat everybody at the level they need with clinical integrity, the level they really need to get better, you can't last the year. You may not even be able to last half a year. And then you're out of money. And then we've got some county commissioners here. What do you say to your county commissioners? Well, I'm out of money. They don't want to hear that. So one of the issues we have to look at is what is our resolve to really pay for this disease? Why did we pick this disease to say we're not going to pay enough to treat these people? This is a disease that is responsible for 70 to 80% of the people in our Department of Corrections, in our prisons, and in our jails. It's driving most of our domestic violence, car crashes, child abuse. It's killing our kids. It's killing our loved ones. 1 out of 4 families suffering, really suffering, mostly in silence from this issue. And yet this is the one disease we don't want to pay for. We're not going to fix this one. Why didn't we pick heart disease or diabetes? They're not filling up our prisons. Of course we wouldn't pick a disease like that. The reason is because of stigma. It's because of stigma and shame. So part of our job, and my job as the secretary, and I'm so honored that Governor Corbett went ahead to create this Department of Drug and Alcohol Programs, and I'm honored to be the first secretary of it, because one of the things I will not do is stop talking about how much suffering is going on, how much the level of overdoses, and the fact that we have yet to take care of this problem. 230 years ago, one of the signers of the Declaration of Independence, Benjamin Rush from Philadelphia, said, we have to stop looking at this as something to punish and start looking at it as a disease. And here we are, over 2 centuries later, and we're still fighting over that. It's time to move on and start taking care of the problem. Now, I have spent so much time in the 2 years I've been in this job with parents who have suffered the worst nightmare that any of us who have kids. I got 4 kids. That's a nightmare I don't want to have to wake up into. And yet I've spent so much time, I feel like I carry that with me every day. And I have the pictures up in the lobby of our office. We need to be, first of all, Healthy Pennsylvania. One of the things I'm very, very happy about Governor Corbett's Healthy Pennsylvania is they have decided that under this proposal, those that present with either mental illness or drug and alcohol addiction will be deemed medically frail. They will be eligible for Medicaid, health choices, and under Pennsylvania's Medicaid law, that means they're supposed to get the level of drug and alcohol treatment they clinically need. So one of the responsibilities of this new department, and one of our responsibilities in the state, and I work with your Senator Ward, who is extremely passionate, one of our most passionate legislators about this, to try to find out ways of getting more resources here. Well, under this, anybody under 133% of poverty level will be able to get the coverage they need that will finally pay for the treatment they need. But I could go on for hours, I won't. There are many other things we're doing. We have a prescribing practices work group with medical systems from around the state to identify safest practices, and we have 5 different departments there. What can we do to promote those safer practices? We have an overdose rapid response task force to get the law enforcement, healthcare, treatment communities all communicating with each other in real time, so that we can make sure if we find out fentanyl's popping up somewhere, we can get law enforcement in to make those undercover buys right away. We can make sure our ambulance drivers have the necessary naloxone, whatever they need. And as Senator Ward, by the way, just today, I think, issued a press release with extremely enlightened legislation that will save many, many lives to allow naloxone to be put in the hands of our police officers, our parents, our brothers, our sisters, our family members.
Thank you. I'd love it if you could come back sometimes and meet with a lot of the providers and help provide some input of those coordination of efforts. Where's our coroner? Oh, there you go. Can you come up here a second? Because he just mentioned about as soon as we find these things in people's blood systems, I'm assuming when you're facing one of these death tragedies, autopsy you do, what's the time frame? What happens when you're trying to track what's taking place? Thanks.
We try to be as proactive as possible. When we have an overdose, even though it hasn't been confirmed with toxicology, we share the information with law enforcement. We just ran through this with the Theraflu heroin here recently, got the information out, and it basically went away, Tony, I'd say. We haven't seen it here recently, so we've done that. Other than that, we start to pass on information. We do the best we can with statistics, demographics, and so on, and pass it out to people like you and people like Dirk that took this information, regurgitated it, and make sense out of it. That our numbers continue to climb. Last year we had 86 overdoses, fatal overdoses in Westmoreland County. I started in 2002, we had 22 overdoses. That's a 390% increase in 12 years. That's astonishing. We've already had this year, have 18 overdoses. And there's dozens and dozens and dozens more that pass through the emergency rooms at Excella, because we talked to those people as well. I had a meeting with their EMS providers here last week. Too many of our results in the coroner's level take too long to come in. We're looking at toxicology, if we're lucky, 2 weeks. Final autopsy reports 8 to 12 weeks. So that's not real time enough. So we're trying to work with the EMS people, the healthcare providers, that when something pops up like this Theraflu, we can grab it right away and act on it.
Thank you. Appreciate that. You said 2 weeks though before you get toxicology results. Well, that's I think Allegheny County has their own lab. I think they can do faster, but for the most part, where do you have to send your?
It's a private lab in Willow Grove, National Medical Service.
Okay, that takes a couple weeks. Faster than that, but it would be nice if the police department get the word sooner, if other people get it sooner. Is there, yes?
Yeah, with that overdose rapid response task force, we have a group that's actually, it's with our Department of Health epidemiology group. They have 3 sources of information. Poison control is the fastest. We're trying to get that information in. We also get reports from the ambulance drivers and then from the emergency rooms in the hospitals. Pennsylvania State Police, with Homeland Security money, have agreed to set up a platform. So when that information comes in, we get it onto that platform, and then appropriate stakeholders, whether it's law enforcement, ambulance, treatment programs, they can get that information. We want to get that information across the disciplines within days, rather. It used to be months. And so, like when the fentanyl crisis hit in 2006 and 2007, we lost many, many hundreds of people that we didn't have to lose. Now what we want to do is have, when the information hits, we want it out immediately across state police, DEA, HIDA, and this overdose rapid response task force is, actually Colleen Hughes is a member of it. It has the federal representatives, the DEA, state police, HIDA, chiefs of police, and the district attorneys. So we're working up to all three levels of government on the law enforcement side and on the healthcare side to try to get that community, to break down those walls, get those barriers to communication gone.
That's why we're having you back. Okay, that's why we're working on this. Dr. Wong, do you want to add anything to this in terms of the medical response to the ACs? Dr. Wong from Excella here. Comment these things together. I'm amazed it takes a couple of weeks. I wish we had it in minutes instead of weeks.
Thank you. I've been in family practice over 30